Hello, this is Farzad Pakhtil. International Thyroid Eye Disease Society conducted a virtual instruction course on October 8, 2022. This course was arranged in 2 sessions in 8 hours. Actually, more than 980 participants logged in sometime during these 2 sessions. We had 31 top speakers from all the world. The format of this meeting was to cover different aspects of the thyroid eye disease, from the basics to clinical, including the updates and recent developments in pathophysiology, epidemiology, animal models, biomarkers, orbital imaging, clinical features, and the way that clinicians need to assess these patients, how to formulate treatments, new trends in the treatments, including medical and surgical, and also complications of the surgical managements in patients with thyroid eye disease. We received very positive feedbacks after this meeting from all the world, and our dear colleagues asked us to provide videos of this meeting for watching. Now, I'm very pleased that we could receive consents from some of our speakers. Now we can put the videos in the ITEDS YouTube for watching for a limited time. We hope that we could get more consents and provide more videos for your watching. I would like to thank all of our speakers and my co-directors, Dr. Pierre Dolman, Dr. Jonathan Dutton, Dr. Michael Kazim, and Dr. Seeley Lang. Without all of these great people, we could never conduct such a great and instructive meeting. So I hope you enjoy watching these videos and look forward to seeing you in future ITEDS meetings.
Hello everyone, I am Magan Potvin. On behalf of my promoter Peru Said, I'll be discussing the topic of dysthyroid optic neuropathy, or DON. Let's start off with some background information. DON occurs in about 5 to 8% of Graves' orbitopathy patients. The main risk factors are higher age. It has a higher male to female ratio compared to normal Graves' orbitopathy. Smoking is definitely a risk factor. The myogenic type compared to the adipogenic type. Stress, whether it be from infection, surgery, or psychological stress like the loss of a loved one or a divorce, for example. Diabetes, probably due to vasculopathy, and hyperthyroidism. So pathogenically, several mechanisms have been proposed. Compression of the optic nerve at the apex, either directly, thus impairing exoplasmic flow, or indirectly through microvascular ischemia, seems like one of the most likely factors. The medial rectus lies most adjacent to the optic nerve, followed by the superior rectus, and enlargement of these muscles probably holds the largest danger to the function of the nerve. Stretching has also been coined in the past, although in 2020, Jeffrey Rose and his colleagues specifically investigated this mechanism, and they found that although optic nerve length, radiological proptosis, and orbital nerve angle were significantly higher, the optic nerve did not reach its elastic limits. And they concluded that for most patients, stretching of the optic nerve was not a causative factor, although it might render the nerve more susceptible to other forms of injury like compression or inflammation. Optic neuritis due to neighboring inflammation has also been suggested, although histologic examination of optic nerves of DON patients did not reveal any inflammatory infiltration. So patients with DON usually have a rapid onset of complaints. They occur bilaterally mostly, and they complain of blurring of vision and desaturation of colors. Clinically, we use several criteria to diagnose it, usually at least 2 of the following. The best corrected visual acuity, so mainly a decrease compared to the previous measurement. There's no perfect cutoff value. Color vision testing, Ishihara tests are less sensitive than a Farnsworth Hue test, but they are more practical. A recent study found that trident deficiency was very specific for DON and was in fact the earliest sign of abnormal function of the nerve. Visual field defects are mainly found in the central and paracentral area, often inferiorly. Optic nerve head edema is highly specific for DON, but it lacks sensitivity. And the same is true for an RAPD, especially in bilateral cases. And then finally, a pattern VEP shows increased latency and decreased amplitude, but it is time-consuming exam, and it definitely is not always available. It should be noted that not all patients with DON show strong clinical inflammation. A UGOGO study found that about 25% of patients had a CAS of 3 or less, and there are no golden standard criteria. So we use these clinical criteria, but they're not golden standard. Imaging is often supportive. I think most clinicians probably use CT because it's readily available, fast, and it defines the bony anatomy very nicely, which allows for surgical planning. The downside of CT is the radiation. CT of the head administers about the amount of radiation that is equivalent to 5 months of background radiation. An MRI offers more soft tissue detail and the option of evaluating inflammation as well through diffusion-weighted imaging and short tau inversion recovery sequences. The disadvantages are the availability and the bony anatomy that is less well defined, although it does allow for surgical planning. So many factors have been studied in the past. I think the factor with the most diagnostic value is the medial rectus diameter. It has been shown to be an independent significant predictor of DON in multivariable models. Some value probably also goes to severe apical crowding, whether it be categorically scored, or area or volume based. And also the thickness of the other EOMs have some value. And then many of the other factors are controversial. Some studies find they have some use or some diagnostic value, others don't. And also for the imaging, there are no definite criteria. MRI, as I said, allows for evaluation of inflammation. And in DON, it's been shown that optic nerve diffusivity and fractional anisotropy might play a role in the diagnosis, might have some value. And recently, we also studied the signal intensity ratio and relative apparent diffusion coefficients of the EOMs compared to the temporalis muscle. And we found that the medial rectus diameter, superior rectus and inferior rectus RADC, and the limitation of depression, so a clinical parameter, were independent significant predictors in 3 different multivariable models. Each 3 of them had a nice sensitivity, specificity, and positive and negative predictive value. So the management, DON is an emergency which should be handled by a multidisciplinary team in a specialized center. We should always strive for a euthyroid state and urge the patient to stop smoking. We should always avoid the use of radioactive iodine because that can deteriorate inflammation. And the first line of treatment is usually IV steroids, so methylprednisolone, 500 to 1,000 milligrams on a day on 3 consecutive days, with daily ophthalmic monitoring. And after a week, we can check whether the patient can handle the treatment, if it can be continued. If so, and if there is a good response, we repeat it after a week. If not, or there is no or only partial response or clinical deterioration, we move on to surgical decompression. Now, surgical decompression does not provide a better outcome compared to IV steroids as a first-line treatment. So that's why I would start with IV steroids. The IV steroids are effective in about 40% of patients. We should avoid going over a cumulative dose of 8 grams for a patient. And we should definitely check for recent viral hepatitis or severe liver disease, severe cardiovascular disease, uncontrolled hypertension or diabetes, and psychiatric disease, because these things can definitely be deteriorated by the IV steroids. So before we start, we should check for the liver enzymes, viral hepatitis markers, fasting glycemia, a liver ultrasound, and check the blood pressure. And we should follow up the liver enzymes, glycemia, and blood pressure monthly. It's also wise to add a proton pump inhibitor and to think of osteoprophylaxis through calcium or vitamin D, and if necessary, bisphosphonates. So surgical decompression, the inferomedial wall is most closely related to the optic nerve, but often a combined decompression of the inferomedial, medial, lateral wall, floor, or fat is performed. The results are independent of the previous use of IV steroids or radiotherapy, but they are dependent of the extent of decompression. So surgical decompression results in a reduction in proptosis, eyelid retraction, and orbital pressure, and possibly improves motility, although there is a risk of new onset diplopia. Radiotherapy does not have a clear role in the treatment of DON. It might be useful for patients refractory to IV steroids who are poor surgical candidates or who refuse surgery. And we should look out for new therapeutic options, including teprotumumab, an IGF-1 receptor antibody, which is safe and effective in the treatment of Graves' orbitopathy and has shown some promising results in DON, or JAK inhibitors, which may suppress the inflammatory cascade in Graves' orbitopathy. But as usual, further studies are needed to reconfirm the efficacy and safety of these compounds. So in conclusion, DON is a sight-threatening emergency. There are no clear diagnostic criteria, so we should rely on clinical and radiologic signs. Prompt treatment is necessary, and the first line is IV steroids, and the visual function or the loss of visual function is mostly reversible if we act early and appropriately. Thank you for your time, and if there are any questions, please shoot.
Good day, everybody. Greetings from Singapore and the Singapore Society of Ophthalmic Plastic Reconstructive Surgery. I'd like to compliment Dr. Farzad and the entire ITEDS team for putting together this beautiful course and inviting me to share my perspective on quality of life in thyroid eye disease. So what is quality of life? The standard of health and comfort of the patient and the happiness experienced by an individual as in a patient afflicted with thyroid eye disease or a group. And in this situation, we're talking about the family, the society, and the nation at large. A large proportion of what I'm going to talk about is what we published in a major review on the quality of life in thyroid eye disease published by various experts from around the world. Not just greetings, but acknowledgements from the numerous people from whom I've learned a lot about thyroid eye disease from. When you look at quality of life, what we're doing is measuring the ability or the disability of the patient affected by the disease. It also helps us understand the disease and its morbidity. And like I mentioned earlier about the individual being affected, the family and the community being affected, and the healthcare resources being distributed and consumed in the management of these patients. It is oftentimes used to assess indications and outcomes of both medical and surgical interventions. And not to forget that a lot of these patients have also residual disease, which have to be looked at too also. We're familiar with the natural history of disease. We're often alluded to the Rundle curve, but keeping in mind that not all patients follow this curve strictly, and it's not usually a single Rundle's curve. And a lot of patients have reactivation over time as time goes by. We tend to think that it's the active inflammatory phase of the disease where people are affected, the quality of life is affected, but you have to remember that not all active inflammatory patients have the congestion, the erythema, injection, so on and so forth. You can have the silent active disease where we oftentimes underdiagnose and undermanage these patients. Again, inactive burnt out phase disease patients also have significant morbidity. And we have to get rid of the mindset this is a short-term active disease and hence focused attention during that period. But remember, these patients have lifelong morbidity, and it's akin to a chronic disease. There are several myths and misconceptions. It's only the active inflammatory phase of the disease where the quality of life is affected. It is oftentimes thought that it's only the severe disease and sight-threatening disease where the quality of life is affected. And only if you're a leading, active, professional, social, physical life, the quality of life is affected. And we used to think in the past that as long as you save the vision of these patients, you have made a big impact in their quality of life. But remember, unlike proptosis, which was initially thought to be causing the significant disfiguration and disability to the patients, the double vision, which I think is more important to be addressed, especially when it's induced diplopia. Here are examples of patients where seemingly an innocuous kind of disease, where the patient's quality of life is moderately affected, whereas a patient like this who's got obvious severe proptosis with strabismus and is able to suppress the second vision is really not really affected as well. So why is this important? Quality of life assessment is important in determining the threshold for intervention, determining the success and outcomes of intervention, be it medical or surgical, orbital, muscle, or eyelid itself. In the diagnosis and management of thyroid eye disease, we always talk about the 4 questions. First question is always, is it or is it not thyroid eye disease? Is it the active inflammatory phase of the disease where all these immunomodulating agents may be of role, versus the inactive disease where we are already conservatively managing them or doing rehabilitative work? Is it, in terms of severity of the disease, mild, moderate to severe, or sight-threatening disease? And the UGOGO 2021 protocol rightly acknowledges the role of quality of assessment even in patients with mild disease. And you can see it in this particular flow path where we talk about even in mild patients with mild disease, if the quality of life is affected, doing various forms of intervention is very important in these patients. And of course, it's well known that moderate to severe disease require more attention. Examples of patients with early active disease with proactive management with high-dose intravenous protocol treatment were able to make a difference not only the way they feel, but also the way they appear. A dilemma always arises in patients with compressive optic neuropathy and orthophoric eyes, where in the name of decompression, we end up using diplopia, which can cause significant disability, following which strabismus surgery is done, where we are able to restore the original form and function. Examples of patients where you have balanced decompression with good outcomes. So which quality of life tool do we really use and why? If you look at the evolution of the various quality of life questionnaires, you can classify them into the general health quality of life questionnaires, which used to be done in the past. Then there are specific disease-specific quality of life questionnaires, which are probably the most popular ones, vision-specific questionnaires, and finally the semi-structured interviews, and we'll touch a little bit of each of as well. This is very good for systemic disease, but not very good for thyroid eye disease, and hence by default we go to the disease-specific questionnaires, where the 2 famous ones are the GOQOL questionnaire from the Amsterdam group and the thyroid eye disease quality of life questionnaire from the Vancouver University of British Columbia group, and a few other versions as well. These can be classified into multiple item questionnaires as the GOQOL, which is more detailed and useful in research studies, although it can be a little time consuming, or the single item questionnaires, which is a TEDQOL, which is simple, easy, fast, although it may be less specific. So the mecca of thyroid eye disease or Graves' orbitopathy studies, where all came from Amsterdam, this is the very first disease-specific questionnaire, which has been translated into several languages. It has been shown to be very valid in the first questionnaire to show that an average afflicted patient with thyroid eye disease quality of life is much worse than a healthy American population, and is much worse than patients with diabetes, emphysema, and heart failure, all of which can significantly affect the patient itself. It has been the most studied and validated and been used extensively in the various clinical trials and correlates fairly well with the activity and severity of the disease. But the problem is it's a detail, and hence the completion rate is only about 78%. These are some other vision functioning and the appearance questionnaires related to the GOQOL. There was a quality of life study which is not used as much as was initially published, but one of the most popular ones, and is universally utilized nowadays, is the TED quality of life questionnaire by Fayers and Dolman from 2011, where it basically addresses 3 issues: overall quality of life, daily functioning, and the appearance on a visual analog scale, which is very easy to. And the greatest advantage is these questionnaires can be used in such a way that there's a 100% completion rate. It's a validated and reliable questionnaire and correlates fairly well with the GOQOL and also correlates well with surgical outcomes. The problem is the simplicity. Because of the ceiling effect, In patients who are already presenting with significant affection of quality of life, progression may not be well monitored in such patients. Then there's a cultural specific Singapore thyroid eye disease quality of life score, which has also been utilized quite well. It's got 10 questions along with 4 quality of life domains. While the strengths are this, it's culture specific and the completion rate is high, it has not been quite validated in large numbers. The fourth form of the quality of life assessment scores are the semi-structured interviews, which are very detailed, very complex, takes an elaborate amount of time, almost up to an hour, to really address the various aspects of the thyroid eye disease affecting the patient's individual quality of life, economically, physically, medically, cosmetically, so on and so forth. But actually, it's very good to address new issues, including anxiety, depression, which are very important and has been neglected in the past. So in summary, which one should you use? You basically keep in mind that in thyroid eye disease, you have to answer the 4 questions. And the fourth important question is the quality of life. Try to use disease-specific questionnaires. In a busy clinic, it is okay to use a thyroid eye disease quality of life score, which is good for screening and clinic use. Versus if you're doing a research studies protocols or doing a more elaborate assessment of patients, try to use the GOQOL. It is important that if you really want to understand the disease, then you may have to use semi-structured analysis. In my personal opinion, a consultant's time in dealing with the patient in either the first consultation or subsequently before and after medical treatments and surgical treatments are offered is very similar to a semi-structured analysis. And keeping in mind that all of the treatment that we now do for our thyroid eye disease patients is not just by a blind protocol, but a tailored and active management to these patients so that the patient's personal needs are taken care of. And these quality of life studies are also very important for healthcare resources, whether you have to lobby your own institution to provide more time, space, or care, both clinical and operating theater care, to ensure that we offer the best care for our patients. Healthcare resources allocation is very important. And you can also prove efficacy of various interventions justifying the time invested in managing these patients. In the future, we have to do a little bit more detailed analysis, and that's where the questionnaires really come in, to study specifically the anxiety, depression, self-esteem. It is even proposed that there's higher risk of suicidal ideation in these patients. Remember that passive and proactive management also have to be taken in consideration, and these patients who have chronic disease do not ignore the long-term patients so that we are able to address their quality of life. Thank you very much for your kind attention, and I'm happy to take any questions, which you can email me when possible. Thank you very much, Prasad.
Hello, everybody. We're going to talk about keratopathy in thyroid eye disease. This is my only financial disclosure. We'll begin with the case. This was a young female who presented to us several years ago. Severe ocular surface changes. The clinical picture was suggestive of a burnt out thyroid eye disease, and she had barely perception of light in both eyes. The CT scan was suggestive of a fat predominant disease and an optic nerve stretch. We attained euthyroid status, and then orbital decompression was done sequentially, followed by eyelid surgeries. In the right eye, for the corneal scar of right eye, penetrating keratoplasty was done, followed by cataract surgery, and she attained a 20/50 vision in the right eye. Quite unimaginable if we look at the clinical presentation. Keratopathy in thyroid eye disease could present in the form of punctate epithelopathy to corneal clouding to a full-blown microbial keratitis with or without decimetocele. The ocular surface disease has quite a high prevalence in thyroid eye disease. And depending upon whether we take subjective or objective criteria, almost 2/3 of patients with thyroid eye disease have an ocular surface problem. This kind of a milieu may be the setting to cause more fulminant corneal breakdown. If we try and understand the pathogenesis of ocular surface disease in TED, what is often talked about is about surface exposure or even altered blink dynamics. But new evidence has emerged in the literature which suggests that there are alterations in the tear film characteristics, rather in all layers of the tear film, in the meibomian gland architecture and dropout, and interestingly, cytokines predominantly pro-inflammatory in the tear film, which correlate well with the activity of the disease. In this setting, it's important to understand that from a common change in the ocular surface milieu, we have a full-blown keratopathy and corneal breakdown. If you look at the evaluation of ocular surface in thyroid eye disease, most classification systems are restricted to looking at stippling of the cornea, to ulceration, to perforation of the cornea. What is probably needed is a more elaborate evaluation of the ocular surface, both subjective, could be in the form of OSDI questionnaire, two objective parameters like the tear breakup time, Schirmer's test, tear film osmolarity, and cytokine levels. Imaging is, of course, useful in a setting where additional dysthyroid optic neuropathy is suspected. In patients with microbial keratitis in one eye, it's always challenging to grade severity. We have, for quite some time, used the fellow eye to grade the severity. Alternatively, one can also use an MRI hyperintensity or signal intensity ratios, which has a close correlation with the activity of the disease. In the setting of apical crowding, of course, imaging becomes extremely useful. There is sparse information about microbial keratitis in TED, and two large series have been published. One from our own institute showed a 1.3% prevalence of microbial keratitis. 92% were active, most were moderate to severe disease, and none had microbial keratitis with DON. Unfortunately, a large majority had poor visual recovery, and 4 needed evisceration. Another large series published from over 2 decades of experience with TED showed less than 2% had corneal ulcers. Here, however, 50% had associated dysthyroid optic neuropathy. Again, suboptimal visual recovery and aggressive therapy was necessary in management. Risk factors for keratopathy have been elusive, and our own experience with 202 patients showed that while smoking, systemic disease of diabetic mellitus, and older age were clear risk factors for DON, none of them were significant for corneal breakdown. If we talk about managing keratopathy, one has to probably use one of the existing severity scales to put the patient into either the mild or the moderate to severe types. In the milder versions, medical therapy of lubrication, moist chamber glasses are usually enough. Whereas in moderate to severe types, one may resort to either topical cyclosporin, topical steroids, and liberal usage of tarsorrhaphy to protect the surface. What is very much needed is a more elaborate evaluation, as mentioned earlier, about the ocular surface and to look for risk factors. In full-blown corneal breakdown in inactive disease, one has to give a tectonic support in the form of amniotic membrane graft or a cyanoacrylic glue, followed by definitive surgery. However, in active patients, stabilization of both the general disease and the ocular disease are both important before definitive surgery. In recalcitrant ones, emergency decompression and eyelid surgery becomes necessary. This lady presented with a full-blown microbial keratitis with a fungal cultures in the left eye with a contraindication for corticosteroids. She underwent a bilateral decompression and tarsorrhaphy in the left eye. And this is 1 week after surgery, showing stabilization and resolution of the disease. To summarize, keratopathy has a fairly common prevalence of ocular surface disease in almost 2/3 of patients. And few of them develop corneal breakdown. And this is about less than 2%, but a significant and a sight-threatening complication, as we know. New information in changes related to tear film, corneal biomechanical properties, and pro-inflammatory cytokines is key to understanding the pathogenesis of corneal breakdown and ocular surface milieu in thyroid eye disease. Unfortunately, a large majority of those with corneal breakdown have poor visual recovery, necessitating aggressive therapy. We feel that evaluation of the ocular surface needs to be more elaborate in TED, and there is much needed at this time are risk factors predicting progression to corneal breakdown. Therapy in keratopathy in thyroid eye disease setting has to be individualized. Thank you.
Hello everyone, my name is Dr. Milind Naik and I practice at the LV Prasad Eye Institute in Hyderabad, India. Congratulations to ITEDS, particularly Farzad, for organizing this wonderful online event focused entirely on thyroid eye disease. In my talk, I shall be focusing on eyelid considerations in thyroid eye disease. Here is the financial disclosure for my presentation. We all are aware of the classic thyroid eye disease paradigm of management, where we address the proptosis first, followed by motility, then eyelid, and finally aesthetic considerations. My talk will be mainly about the last two. So today we'll talk about eyelid retraction, ptosis, entropion, and aesthetics of the eyelid in thyroid eye disease. Lid retraction can be either upper eyelid in the form of mild, moderate, or severe, or the lower eyelid, again in the form of mild, moderate, or severe. The management of eyelid retraction can either be in the active phase or in the inactive phase. In the active phase, it can either be a functional problem or a cosmetic concern. Usually, injectables are preferred in the active phase of the disease and surgical options in the inactive phase. During the active phase, the treatment options for eyelid retraction include botulinum toxin injection, filler gel, and triamcinolone acetonide as injectables, and a tarsorrhaphy for functional problems. If you look at this busy slide comparing the toxin, the hyaluronic acid gel, and triamcinolone for eyelid retraction, triamcinolone can be therapeutic and long-lasting if it targets the disease in the early active phase. Here is an example of a left mild upper eyelid retraction, which was treated with 2.5 units of botulinum toxin to achieve symmetry. Here is a lady with right mild upper eyelid retraction with downgaze lag, which was treated with triamcinolone acetonide injection. You can see the improvement on the right side, and subsequently she started to develop mild left upper eyelid retraction. Hyaluronic acid gel can also add weight to the upper eyelid and improve mild upper eyelid retraction. Tarsorrhaphy is almost always indicated in functional cases such as keratopathy and infectious keratitis, which can either be in the form of lateral paramedian or an extreme lateral tarsorrhaphy. In the inactive phase of the disease, we can target either the Mueller's muscle, perform a levator recession, or a full thickness blepharotomy. Extreme lateral tarsorrhaphy is a very good option for mild upper and lower eyelid retraction to correct that temporal flare. With Mueller muscle, we can either perform recession with suture, or Muellerectomy. Muellerectomy is the most popular procedure performed for mild upper eyelid retraction. An incision at the upper edge of the tarsus is placed. The Mueller's muscle and the levator are exposed. The Mueller's muscle is separated from the levator anteriorly and the conjunctiva posteriorly, and it is excised along its entire vertical and horizontal length. The conjunctiva is placed back with fibrin glue. Here is a preoperative and postoperative picture of a patient who underwent left upper eyelid Muellerectomy for mild upper eyelid retraction. Levator recession is performed for moderate upper eyelid retraction, an eyelid crease incision, exposure of the levator, and graded separation of the levator from the upper edge of tarsus, with or without release of the lateral horn, is performed to achieve the desired height of the upper eyelid. Pre- and post-operative photographs of a patient who underwent right levator recession. Full thickness blepharotomy is preferred for severe upper eyelid retraction, where a lid crease incision is placed, the tarsus and the levator are exposed, and the entire extent of the eyelid is incised, including the conjunctiva, leaving a small band of intact conjunctiva in the center to maintain the contour. Here is a pre- and post-operative result of a patient who underwent full thickness blepharotomy on the left side. Lower eyelid retraction can occur in the setting of thyroid eye disease either as a pre-existing finding or post-strabismus surgery. A forced upward traction test gives a fair idea of the tightness of the lower eyelid retractors, which can be released transconjunctivally so as to reduce the inferior scleral show in cases of mild to moderate amount of lower eyelid retraction. For severe inferior scleral show, however, a floor decompression is very effective to move the eyeball down so that the inferior scleral show can be fully corrected. Talking about ptosis in thyroid eye disease, we pulled out a small cohort of patients who presented with ptosis and found that 2/3 were due to aponeurotic cause and 1/3 were myasthenics. Possibly increased orbital fat could be a risk factor to separate the levator from the tarsal conjunctiva due to the increased orbital fat. When proptosis presents along with levator dehiscence in these patients, a combined surgery can be done to reattach the levator and an orbital decompression. Entropion is a rare but possible finding in patients who present with thyroid eye disease, and it can either be unilateral or bilateral. It can either present just in the medial half of the eyelid or along the entire lower eyelid length. Ultrasound biomicroscopy showed that thickened middle lamella was a possible contributory factor. Most of these cases, however, resolve after a transconjunctival incision taken for the floor and medial wall decompression. Finally, coming to a few points about the aesthetics, patients with thyroid eye disease due to the eyelid retraction and the excess light falling onto the eye have overacting glabular muscles leading to glabular folds which can be treated with botulinum toxin. Similarly, residual under eye fat or even under eye hollows can be treated with fillers or a blepharoplasty to improve cosmesis. In summary, we looked at some of the commonly performed procedures for upper eyelid retraction, presentation of ptosis in thyroid eye disease, a rare presentation of entropion, and finally a few aesthetic concerns in these patients. Thank you very much, and I appreciate the opportunity to present at the ITEDS symposium.
First of all, I would like to thank the organizer for inviting me. The subject of my talk is clinical trials in thyroid eye disease. Clinical trials are studies in humans that are designed to answer specific questions, especially about treatments. They should be conducted after approval, and they can involve one or more center or in one or more country. They can be sponsored by a company or by the government, and only 10% of them result in approval of the investigated drug. Clinical trials can be observational or interventional, and the last ones are the ones that are more employed in the case of thyroid eye disease because they are designed to investigate new treatments. They can be classified based on their so-called phase, from phase 0 to phase 4, and the features of each phase are depicted in this picture. I won't go too much into detail because of time limits. Concerning TED, or Graves' orbitopathy as we like to call it in Europe, clinical trials are aimed at investigating the efficacy and the safety of novel treatment procedures, and several trials are being conducted in the last few years. For example, according to the European Group on Graves Orbitopathy guidelines, treatment of mild GO can include the selenium supplementation, which is derived from a multicenter clinical trial. The same applies for moderate to severe inactive GO, for which UGOGO proposes as the first-line treatment an association between intravenous methylprednisolone and mycophenolate based on a recent randomized clinical trial. Likewise, most of the second-line treatment for GO derive from clinical trials like cyclosporine from old studies, or the association between orbital radiotherapy and oral or intravenous glucocorticoids, teprotumumab, rituximab, or tocilizumab. The recent acquisitions on the pathogenesis of GO have allowed the identification of several molecular targets for drugs, and that are the subjects of several clinical trials that are ongoing or that have been performed lately. When designing a clinical trial, there are a few key points that have to be taken into account: the background, the study design, the sample size, and the outcomes. The background based on which a clinical trial is designed is preliminary evidence that comes from clinical data, for example, case reports or retrospective studies, or preliminary evidence that comes from basic studies. An example is the studies we have conducted on the use of statins in GO that are based on the observation that statins protect from developing GO in patients with Graves' disease. Other examples are the studies on teprotumumab that are derived directly from lab studies beautifully conducted by the group of Terry Smith, for example. Interventional studies on medication can be of two types, and they can be a drug or a procedure versus placebo, as for example in the teprotumumab studies, or a drug or a procedure versus standard treatment. As I told you earlier, clinical trials can be multicenters, as for example the studies on teprotumumab, or they can involve a single center, as the study we performed recently on statins. Another key point is masking. Of course, a study against placebo is supposed to be double-blind and thus masked, whether studies against standard treatment, for example, intravenous glucocorticoids, are often open-label because it is impossible to mask patients. The calculation of the sample size is essential in planning a clinical study, and it is critical to understand that different study designs need different methods of sample size calculation. Sample size is generally intended as the number of patients that is sufficient to achieve statistical significance for the primary outcome measure based on preliminary data. A key point in clinical trials in GO is the definition of the study outcomes. Several primary outcome measures have been used in different studies. One uses a composite evaluation of GO, and GO is considered improved when at least two of the following criteria in the study eye are fulfilled without worsening in the other eye, and these are an improvement of proptosis, an improvement of the clinical activity score, of eyelid aperture, of diplopia, or of eye ductions, and of visual acuity. In other studies, however, the primary outcome measure was an improvement of the clinical activity score, as, for example, in the studies on teprotumumab. Let's now see a few details on the most recent clinical trials conducted in GO, in which the following drugs or procedures were investigated, namely rituximab, teprotumumab, mycophenolate, the association of radiotherapy and azathioprine, tocilizumab, and atorvastatin. Rituximab is a chimeric murine human monoclonal antibody against the CD20 molecule that is present on B cells. CD20 is present all across the development of B cells, but not in plasma cells. Although the role of antibodies in the pathogenesis of GO remains to be established with certainty, it is very likely that B cells function as antigen-presenting cells in orbital tissues of patients with GO. Thus, B cells are present in the orbital infiltrate of GO patients, and their number correlates with the clinical activity score, suggesting that they play a role in the pathogenesis of the disease, and which has posed the basis for investigating whether rituximab can have any effects in patients with GO. 2 clinical trials have been conducted for rituximab in GO, one in Italy by the group of Mario Salvi. In these clinical trials, patients were randomized to receive intravenous methylprednisolone or rituximab, and the primary outcome measure was the reduction of the clinical activity score, which was greater in the group given rituximab than in the group given cortisone, beginning at 12 weeks from the beginning of treatment. However, in another study performed at the Mayo Clinic, it was shown that there was no difference between rituximab against placebo. One possible explanation for the discrepancy is the different duration of the disease, which was shorter in the Italian study compared with the American study. As mentioned earlier, mycophenolate has been proposed by UGOGO in association with intravenous glucocorticoids as the first-line treatment for GO. Mycophenolate inhibits inosine monophosphate dehydrogenase, which results in decreased antibody production by B cells and in an antiproliferative effect on both B and T cells. Moreover, it induces apoptosis of activated T cells and inhibits expression of adhesion molecules and recruitment of immune cells. Furthermore, mycophenolate inhibits fibroblast proliferation and functions, and is available as mycophenolate mofetil and/or enteric-coated mycophenolate sodium. UGOGO conducted a multicenter randomized clinical trial in which mycophenolate was added to methylprednisolone and compared to methylprednisolone alone in active moderate to severe GO. The primary outcome measure was the improvement of GO according to the composite evaluation at 12 weeks, which was not fulfilled. However, a post-hoc analysis revealed a better improvement of GO at week 24 and at week 36 in patients given the combination treatment. The most important drug which use has been introduced in the clinical practice, at least in the US, is certainly teprotumumab. Teprotumumab is a monoclonal antibody against the IGF-1 receptor, which is physically related in orbital fibroblasts from GO patients with the TSH receptor, and the inhibition of the IGF receptor with a blocking antibody, which is, by the way, teprotumumab, reduces signaling through the TSH receptor. The idea is that IGF-1 receptor and TSH receptor interact to form a complex that is inhibited by a monoclonal blocking antibody against IGF-1 receptor. And this antibody is teprotumumab, which by binding to the IGF-1 receptor blocks the pathway of the activated receptor. 2 randomized clinical trials on teprotumumab have been conducted. They were both multicenter, and they were both against placebo, and the results were actually amazing. Treatment with teprotumumab compared with placebo resulted in a marked reduction of proptosis, of the clinical activity score, of the quality of life of patients, which was the case in both trials. Another drug investigated recently is azathioprine. Azathioprine is an antiproliferative agent similar to mycophenolate. In one previous uncontrolled trial, it was found ineffective in GO as a single agent, but observational studies suggested a benefit in combination with low-dose glucocorticoids. The CIRTED study is a multi-center British clinical trial designed to investigate the combination of azathioprine and radiotherapy for GO. Patients were randomized into 4 groups, one receiving radiotherapy and azathioprine, one receiving sham irradiation and azathioprine, one receiving radiotherapy and placebo, and one receiving sham irradiation and placebo. Whereas radiotherapy did not seem to have any effects, azathioprine had a beneficial effect on the outcome of GO. However, the study has a major limitation, which is a very high dropout rate, presumably due to the adverse events related to azathioprine. A brief mention on tocilizumab. Tocilizumab is a monoclonal antibody against the IL-6 receptor, which is presumably involved in the pathogenesis of GO. A small clinical trial on rituximab was conducted in Spain, resulting in a beneficial effect in GO, and one randomized clinical trial is currently ongoing in Italy. Finally, I will conclude with statins. Statins can have a beneficial effect in GO because of their direct anti-inflammatory actions due to their so-called pleiotropic effect, or because they reduce cholesterol, which is increased in GO patients compared to non-GO patients within Graves' disease. Based on the observation that statins exert a protective role on the development of GO in patients with Graves' disease, we conducted a single-center, open-label, randomized clinical trial in which statins were added to intravenous glucocorticoids and compared with glucocorticoids alone. The primary outcome of the study was the overall response of GO to treatment at 24 weeks using the composite evaluation, and the proportion of responders was higher in the group given statin plus methylprednisolone compared with those given only methylprednisolone, as shown in this slide. In addition, patients in the statin group had a better quality of life both at 12 and 24 weeks, suggesting that the addition of statins may be helpful in treating patients with GO when intravenous glucocorticoids are planned. Hoping that more clinical trials will come out in the next few years, I would like to thank all of you for your attention.